Okay, so this is week 2 for my clinical rotation journal, and I wanted to touch on countertransference. Um, I think as a nurse, as much as I've tried to not let it become an issue, it does. I mean, we're human, we work in this field every day. And I think our own feelings come into play with some of our patients. So I'm going to talk about a patient we actually saw during clinicals. She's well known to the facility. She's been in and out of our level 1 psychiatric hospital for years. She has borderline personality disorder, and has multiple gestures of suicide. So the night prior, it was reported that she had used a pillowcase to wrap around her neck, gesturing that she was going to strangulate herself with it. So the nurse called the on-call provider and gave IM orders of Zydus or Zyprexa 10, 2 of Ativan, and 50 of Benadryl. So this is a patient that comes in and wants injections. And so she knows the system very well. She knows what to do and how to do it to get what she wants. And so previous admissions, there's always, it is always well known to the on-call providers that IMs are not to be given to the patient. Redirection, oral medications are to be offered prior. And so it wasn't done. The patient was reported to get her, the quote unquote booty juice, and was reported to sleep well. So then when we saw her, our physician has a heart-to-heart with our reoccurrence patients and says, look, we know where you're getting at and we know what you're trying to do. And she literally laughed and said, but I got it. And so a little bit of bias and prejudice and anger came on me, mainly because it digs under your skin, borderline. They have this disorder where they know where to trigger you and get you. And 2, because upon admission they fail to put this as part of their treatment plan, is that PO medications will be offered and ordered. She's voluntary. So malingering is something that I'm really not venturing, but really learning about, the way that the social worker approached her, because everybody knows her very well. What are your intentions? The next step that I suggested was to call the insurance company, because I'm sure she's a high utilizer, and come up with a plan with Medicare and Medicaid on, okay, what do we do as a team? Because giving her high, giving her meds, and then discharging her isn't working. We see her every month, and we're level 1. She's not court ordered. She comes in and says, I'm going to kill myself, and we have to assess her on the Columbia score. She scores really high because she's had previous attempts, and so we all see her name and we all kind of like cringe, like, oh, it's her again. And so I kind of caught myself on the provider point of view now, like, okay, what do we do? Because what we're doing isn't working. So who else can we get involved? What else can we do to approach this discharge differently? Her family has disowned her. Everybody is tired of her behavior, typical borderline, relationship issues, doesn't have any kids, is disabled, is on welfare, and you're here because of me. How else can we approach it? So I did some research, and so I'm going to be giving some input. I was a case manager for an insurance company, and I managed high utilizers. So I'm really interested to see, is she considered one? Does she have an insurance case manager that we can work with and figure out maybe a level 2, longer stay, or what can we do to work together on it? She's also been through ECT before, kind of like a reset, didn't work. She has gestures of SI, and will verbalize a plan. However, nothing has ever been a actual followed through plan. She verbalizes, she knows what to say, how to get her way, and so that my own judgment and bias and seeing her name and just a sigh and here we go again, I kind of caught myself on this side of the table as a provider versus a nurse. So what can I do to impact this? Who can I reach out to? How does a heart-to-heart with her go? What does she want? Other than what she's already done before. It's kind of like the social worker approached her was, okay, what do you want? How can we help you? Because you keep coming here voluntarily. Well, I want to kill myself. Okay, so what we've done, where you come in, you stay, your 10 days, we discharge you with a plan, you don't follow up, and you come back, isn't working. So how do we help you? Do you want to continue to hurt yourself? Well, not that I'm in here anymore. Okay, so when we discharge you and you go home, that's when you want to kill yourself. And she kind of like pondered, very taking her time to choose her words on what to say. But anyhow, that would be my counter transference of my own bias, my own judgment on borderline personality from both a personal perspective, and as a nurse, just kind of seeing it from a different view. Stepping back, taking a deep breath and say, okay, how can we approach it this time? What suggestions can I give? What would I do if I was a provider? How would I work with my admissions team and my administration team on taking a different approach? So I think those are all things that I would take with me with these cases, is how can I make a change?